USMLE Step 1 Cardiovascular System, presented by USMLE Forum of Pakistan. Welcome, guys. Today we'll be continuing on with the series. A 46-year-old man with a 30-pack year smoking history develops right leg pain and swelling. He started on intravenous heparin, and the diagnosis is confirmed that lower extremity DVT is there. So he develops right-sided weakness and a facial droop, which signifies that there's a stroke attack. CT scan reveals a stroke. Okay, so they made it quite easy. What are the physical exam findings? Of course, we're doing cardiovascular, so every option is relating to the heart. So, what is basically the important concept that you need to understand is that a person that is returning from an overseas trip and then he is diagnosed with a DVT, if they would have not given you that he's diagnosed with a DVT, you should have still identified that returning from a trip is a risk factor for developing deep venous thrombosis. Prolonged immobilization, pregnant or obese females, and hypercoagulability of any kind. These are risk factors for deep venous thrombosis. But they have already given that in the question. Now the person develops a stroke. Normally, deep venous thrombosis can give rise to pulmonary edema, but pulmonary edema is not seen in this case. In this case, stroke is seen. So, how can a person go from having a DVT to having a stroke? How does that relate with each other? Because a DVT is starting from the venous system, and a stroke can be present in an arterial system, right? Because they're saying that the MCA is occluded. So, how can a stroke go from the veins to the arteries? The problem lies in the heart. This concept you need to understand. Number one, that to go from veins to the arteries, you must have an ASD, an atrial septal defect, or any defect of the interventricular septum of the heart can give rise to that. But classically, atrial septal defect is seen with this in this case. In reality, any defect of the interventricular septum can give rise to this, as I said. But classically, it is the ASD. So they're asking that what would be the findings in this patient, essentially, if he has ASD. One thing that I forgot to mention is these kind of emboli are known as paradoxical emboli. Paradoxical, right? PARADOXICAL, paradoxical emboli. They're known as paradoxical because they're not supposed to cause any problem in the arterial system. If an emboli is dislodged in the venous system, it is supposed to cause symptoms in the venous system, but it is dislodged from the venous system and is causing symptoms in the arterial system. So that is why it is known as paradoxical emboli. So the person has ASD. This is a high-yield factoid that paradoxical emboli occurs in people with ASD. And what is paradoxical emboli? Deep venous thrombosis causing a stroke. All right? You have to remember those facts. Next, what you need to know is what is the finding of ASD when the heart is auscultated. That is what you need to know. So going through these options, the diastolic decrescendo type murmur. Now, you have to understand that this option is relating to aortic regurg. Because first of all, it is a diastolic type of murmur. And it is a decrescendo type of murmur, which means it is decreasing in its intensity. So this is pointing towards aortic regurgitation. What does amyl nitrate mean? Because this is a nitrite. You can see this is nitrite. So what it does is it decreases the preload. It causes venodilation, and it decreases the preload of the heart. More blood is getting pooled in the venous system, which means there is less blood in the heart present. So I would tell you this fact that you need to remember. Another fact, it's fact number 2, we should call it, all right, that all the murmurs of the heart, they decrease when the blood in the heart decreases, and all the murmurs of the heart increase when the blood in the heart, present in the heart, increases. So all the murmurs will decrease when the preload of the heart decreases. There is less blood in the heart, and all of them would decrease where the preload would be increased and there is more blood in the heart. That is a fact. But there are a few exceptions. The number one exception is hypertrophic cardiomyopathy. You need to remember that is high yield. The murmur of hypertrophic cardiac myopathy would increase if there is more blood in the heart, and would decrease if there is less blood in the heart. So that is important. I have an illustration in the next slide, which is going to clear that up. So aortic regurg has no significance in this question. So this is the wrong answer. It has no significance. We're looking for an AST. So option B, ejection time systolic murmur that decrease on standing. That is a wrong answer. Because as I said, that all the murmurs increase when there is more blood in the heart. When you're standing, the blood goes downwards in the lower extremities of the body due to gravity. So there is less blood in the heart, right? You need to remember these maneuvers also. We'll discuss them in some other video, but you have to remember them. So if this murmur is increasing with standing, which means this is of hypertrophic cardiomyopathy. You need to remember this. This is very important. This is the wrong answer. Presystolic murmur that disappears with atrial fibrillation. Presystolic murmur, first of all, this is the wrong answer. And presystolic murmur, this shows mitral stenosis. Mitral stenosis. And the fact that it decreases with atrial fibrillation just shows that because the atria are contracting more. So when the atria are contracting more, the stenosis of the mitral valve decreases. In the sense, when atria is contracting more in frequency, then the murmur is not heard that much. If something is contracting more, the contraction power increases. So the blockage decreases. Not in reality, but on auscultation, the sound decreases. So you have to remember that presystolic murmur is pointing towards mitral stenosis. Mid-systolic click is again the wrong answer, because mid-systolic click, classically, you have to remember, classically, it points towards mitral valve prolapse. The high yield association with this I can give you is Marfan syndrome or connective tissue disorders. And the Marfan syndrome can also present with aortic regurgitation and aortic regurgitation due to the dilation of the aortic valve. And it can also present with aortic aneurysms. Mitral valve prolapse is also present in acute rheumatic fever. You need to remember that, because we remember mitral stenosis for that, but it can present in acute rheumatic fever. Mitral regurg is presented more, but it can present as well. So all of these are the wrong answers, and we are left with just one, which is wide splitting of S2 that does not change with inspiration. So first of all, you have to know that murmurs that change with respiration are all right-sided murmurs. They're all the right-sided murmurs. The heart, of the tricuspid valve, of the pulmonary valve. And wide splitting, classically, you have to remember this phrase. Putting a star on it, this is a classical phrase that you have to remember for AST. And to further on this point, that wide splitting of S2 plus wide fixed splitting of S2 or fixed splitting of S2, all of these phrases, they point towards atrial septal defect. So you have to remember that. Moving on. These are the maneuvers and the effect of the maneuvers on different kinds of problems, different kinds of valvular problems. So I would want you to remember this table, but right now just concentrate on hypertrophic obstructive cardiomyopathy. Now you can see this column and you can relate to this column that when the blood decreases, the murmur increases in hypertrophic cardiomyopathy, and that is completely opposite for other uh, valvular lesions. As you can see, that it is presented that when the preload increases, the murmurs decrease. The preload decreases, the murmurs decrease. Yes. Excuse me for that. All right. All right. So this question is a bit, it's a bit on the nitpicky side of things. It is more detailed. What are they basically saying is that there is a man that is presented in the clinic with chest pain and dyspnea on exertion and basic case of myocardial infarction. So what happens is that catheterization is planned, and during the procedure, the catheter records periodic pressure changes with a maximum of 25. So this is the first reading, maximum of 25 and the minimum of 2. We could say the systolic, the first reading was 25 and the diastolic was 2. And then the catheter is advanced and it shows the next reading of systolic of 25 again and the diastolic of 10. So the diastolic has increased. So the basic point that you have to remember is when the blood goes from the right to the left, the blood pressure increases, right? Because the systemic pressure is more, the venous system pressure is less, arterial system pressure is more, and the venous system pressure is less. So going from right to left, the pressure increases. That is what you have to remember. So what is happening is it is going from right to left, obviously because the pressure is increasing. The catheter is going from right to left. All right. So we're not present in the left cavity. We are going from right to left. So they're asking that which set of readings was likely obtained, which the first reading. They're asking about what was the first reading, from which location was it obtained from, right? So using logic, all right, you can remember the pressures, but using logic, you can understand that the catheter is going from right to left. It is not present in the left. So we just cancel out the left cavity answers. We just cancel them out. So we're left with 3 options. The right atrium does not have a pressure of 25. All right, it does not have a pressure of 25. And in the previous video, I have also explained that if you want to go logically in this question, and if you don't know that it has a pressure of 25 or not, then we could also assume that in one of the last videos I've explained to you guys that the diastolic pressure depends on the systemic venous resistance, right? So what is happening is that the blood is moving from a compartment of less resistance to a compartment of more resistance. So if the blood is moving from right atrium to the ventricle, there would not be any change. There would not be any change because it is the same cavity. It is the same cavity. So diastolic blood pressure will not change if the blood is moving from one ventricle to another. The diastolic pressure would only change if it is moving from a venous system to an arterial system. The resistance is the same between the atrium and the ventricle. So the catheter is not moving from atrium to ventricle. If it would have been the case, then the systolic pressure would have changed because the amount of the blood changes. In atrium, there is less amount of blood. The ventricle, there is more amount of blood. So the amount of blood changes, which means the systolic pressure might have changed because the ventricles are more strong. Uh, they're more wide. They're more strong. They have more contracting power. So the output changes and the systolic pressure would be expected to change, not the diastolic pressure. But since the diastolic pressure is the only pressure changing, which means that the blood is going from a system of lower resistance to a system of higher resistance, which means the blood is moving from the ventricle to the artery, the ventricle from to the artery. So reading is second reading is obtained from the pulmonary artery, which is the wrong answer in this case. And the first reading is obtained from the ventricle. The blood cannot go from the artery to the atrium to the artery because that is not the pathway it takes. So that is the wrong answer. It has to go in the ventricle first and then to the artery. So the right ventricle is the right answer because the blood is going from the less resistant system to the higher resistance system. So in the pulmonary artery, resistance increases a bit as compared to the venous system. It does not increase as much as the systemic arterial resistance increases, but it decreases relatively more than what it was in the venous system. So I hope that makes it clear. And I have a picture here, so you can also remember this this sequence going from here. So you can remember. You don't need to remember these values; just remember the concept. That's it. And just remember that PCW is equal to the left atrial pressure, the PCWP. If you remember, right? You can see the picture. Pause the video and see the picture. Continuing on with our questions. So, an 18-year-old man suddenly collapses during the game, and there is no trauma, and the resuscitation is initiated, but he dies. So, he had also experienced exertional related chest discomfort and dyspnea, and he has no significant medical history. He took no medications. Going straight into the question, you can understand that he was an athlete, an 18-year-old athlete. So, remember this, an athlete with sudden death due to cardiac causes is hypertrophic cardiomyopathy until proven otherwise. I have explained this in the previous videos also, that it is the hypertrophic cardiomyopathy until proven otherwise. Okay. We just need to figure out the histopathological or the pathological picture seen in the autopsy report. Okay. Looking on the answers, atherosclerotic narrowing of the left anterior descending artery. This is the wrong answer because this is again a classic case of MI, myocardial infarction. And this is going to be more of a chronic picture. And it is very unlikely in an 18-year-old with no history, no medication, nothing. That's the wrong answer. Narration of all cardiac chambers. This is the wrong answer again because it shows dilated cardiomyopathy, DCM. This would likely lead to heart failure. This would not lead to sudden cardiac death. And this is again unlikely in this patient. It's more present in alcoholics or volume overload states. Extracellular deposits and stiff ventricles. This is related to restrictive cardiomyopathy. You can identify that by stiff ventricular walls. And high yield point I can give you is amyloidosis, which is again unlikely in an 18-year-old. So the correct answer is D, which is the myocardial hypertrophy, because the name says it all that hypertrophic cardiomyopathy is the cause with patchy interstitial fibrosis. This is the right answer. E is the wrong answer again because thrombus at the bifurcation of the main pulmonary artery. This shows pulmonary embolism. And again, this would not result in a sudden cardiac death in an athlete. This would more likely be pleuritic chest pain, dyspnea, shortness of breath, and in hypercoagulable patients, in patients with DVT, as we've discussed in the previous question in this video. So that is it. Simple presentation. You can see I've given a picture here of athlete's heart. Chronic exercise. You can see that the walls are increased. Right? You can see that. Read these all. Moving on, a 55-year-old man is come from hypertension, CAD, follow up. He has suboptimal blood pressure control. The physician considers adding verapamil. And which of the following properties of skeletal muscle is responsible for the resistance to medication? So, what you need to remember is verapamil is mostly used for its effect on the heart tissue. It does not affect the skeletal muscle. And the reason for that is because the skeletal muscle depends upon intracellular calcium stores rather than extracellular calcium influx. So I've just given away the answer. The E is the right answer. And how it does this is through, if you could remember, ryanodine receptors. If you remember, they're on the sarcoplasmic reticulum. So what they do is they control the flow of calcium, which is stored inside the muscle cell, and that gives rise to the contraction. So because they don't need the extracellular calcium, and verapamil controls extracellular calcium, so it is not dependent on the effects of verapamil. Okay, so I guess we'll go through the answers now. The CAL modular independent excitation contraction coupling. This is mostly in, this is the wrong answer because this is in smooth muscles. Smooth muscles, all right. Just remember that. It's present in smooth muscles. Decreased troponin affinity. And that is wrong because troponin affinity is not affected. It is the same in both of the muscles, the cardiac and the skeletal muscle. The T tubules are not the reason because verapamil does not work on the T tubular system. It works on the extracellular system, calcium influx. It blocks the calcium channel, which brings in the calcium from the outside. So, of course, any entity that is resistant to its effect would only be that entity which is not dependent on extracellular calcium. And the lack of internal automaticity is irrelevant because, again, verapamil does not affect. So you need to know that verapamil affects calcium channel blockers. It affects the influx of the calcium from the outside. It does not affect the calcium that is present in the inside. But skeletal muscles have a system which uses the calcium that is present in the inside, intracellular calcium. It is not dependent on the calcium that is outside. Cardiac muscles are dependent on the calcium that is outside. That is why verapamil affects the cardiac cells, not the skeletal muscle cells. I hope that is clear.